welcome to all of you. This is the 4 o'clock slot, so we've got to make this pithy and exciting because we're probably the only thing that's keeping you between you and a glass of wine or cocktails or whatever else. And for our discussion today, we really want to talk about what's going to happen to healthcare after COVID. And when I talked about COVID, I always talked about it in BC, DC, and AC. Before COVID, during COVID, and after COVID. But I changed the AC to KAC, kinda after COVID, because we're not quite sure where we are with that. But our field has to evaluate what we've learned and how our environment has changed and how we can improve care as we go forward. It's almost like Rip Van Winkle. We went to sleep in 2019. We went through COVID. Now we woke up, but we're not going to go back to 2019. So what we're going to challenge our panelists today is, then if not 2019, then what? And what are the things we can look at? In my mind, I think the last 2 years have been our field's finest hour. Hospitals and health systems and the brave and compassionate women and men that took care of patients in our communities have been just demonstrating without a doubt the value that our hospitals and health systems have. It may not always seem evident at times, from the public, but I think, we've really had 2 years of this is why we're here. We have a panel of guests with me today that I know will share their insights, they're not shy, about the pandemic, as well as the priorities that we have to look at as we move forward. How do we evolve and improve the care that we deliver for patients, helping them achieve their best health potential? And then what does that full healthcare system, how does it get prepared for the next event as we go forward? So let me do some introductions. Some of them don't need any introduction. Next to me is Dr. Janice Nevin, fellow AHA board member, and president and CEO of ChristianaCare, headquartered in Wilmington, Delaware. Isn't that where the president's from, right? Is that so? That's her other assignment, is to keep an eye on the president for us. ChristianaCare is, we would describe it as a dynamic health system. It includes an extensive network of primary care, outpatient services, home health, urgent care centers, and 3 nationally recognized hospitals. She joined in 2002 ChristianaCare as the chair of family and community medicine, and now has been leading the organization since 2014. Yes. She's led the organization's transformation into a healthcare system that truly impacts health in our community. She's a pioneer and thought leader in value-based care, population health, and is deeply committed to equity, anti-racism, and to making high-quality care more accessible for all. In addition to leading innovation within her own organization, Janice serves on AHA's Committee for Health Strategy and Innovation. Janice, thank you for being with us today.
Thank you so much. Thank you.
Next to Janice is Terry Myerson, the CEO of Truveta, a privacy-safe data company, and was able to join us for today's discussion. After visiting his son at Duke, checking in on him as all dads do and seeing how he's doing in this post-COVID world. But what we've said is that we can't advance care without the important role that data can play in improving health. Truveta's goal is to enable researchers to find cures faster, empower every clinician to be an expert, and help families make the most informed decisions about their care. The organization was founded by a group of health systems who believed that their collective de-identified data could be used to accelerate research, advance health equity, and ultimately save lives. Terry is uniquely suited for this effort as he's been responsible for some of the world's most popular technology platforms. He spent over 20 years at Microsoft as Executive Vice President, overseeing the development of Windows, Office 365, Surface, and even Xbox. Terry, thanks for being here with us today. And now let's go to the screens, and we're also lucky to have with us Andy Slavitt, former senior advisor to the Biden administration leading the COVID response, joining us today. Andy is well known to many of you as he has led the nation's most important healthcare initiatives, serving as the acting administrator for CMS for President Obama and overseeing the turnaround and implementation and defense of the Affordable Care Act. He refers to himself as the outsider's insider, serving and leading private and nonprofit roles in addition to his government services. He's presently a member of the President's Council of Advisors on Science and Technology, working on public health, and also a founding partner of Town Hall Ventures, a healthcare firm that invests in underrepresented communities. Besides that, Andy also has been an author, and a lot of his work we want to explore with him today about what the future is. So Andy, thanks so much for joining us today, and I'm going to dive in with the first question. We talk about caregivers being on the front lines, but in a manner of speaking, you were also on the front line of government response to the pandemic. You released a book last year, Preventable, that offers your account of the United States' coronavirus response. If you could share with us some of those insights, your thoughts on the resiliency and readiness of the nation's healthcare system and public health infrastructure for the next disaster. And Andy, what have we learned?
Well, thank you, Rod, and it's great to be with you. It's great to be with all of you leaders. Janice, great to be on a panel with you. Hello to Terry. Look, the place to start is to think about what do we mean when we say readiness. You know, are we ready? The people mean, I think, three different things. The first thing they mean is sort of a general sort of preparedness. Do we have the infrastructure? Do we have the domestic supply? Do we have the masks and all of the things to keep healthcare workers safe and patients safe? And the truth is, we weren't this time. I suspect we'll be better the next time, but I don't think we can go to sleep on that, because I think there is a sentiment in Washington, a sentiment in Congress right now, not that we should invest more in public health, but actually a reaction to that, which is that we have overinvested in public health. And there is a certain sentiment that says we put too much in the hands of public health leaders, and they were responsible for disrupting our lives as much as the pandemic. So this is not something that I think, it's not a debate that is we can allow to be settled. The second thing people, I think, should mean when they talk about preparedness is, are we scientifically prepared? And there, I think we would all agree to give ourselves quite high marks. You know, everything from the mRNA platform development to the development of eventual development, although I know it felt painfully slow at times, of at-home tests and of therapeutics. But even just the general way in which preprints were continuously circulated, standards of care were adjusted for things like proning and other things. We have to give very high marks, and I'd be very encouraged that scientifically we are up to the task. And then the third thing, and probably the most difficult to assess and talk about, and we think about our preparedness, is are we prepared as a society? Are we prepared politically? Are we prepared to support one another? When we have an infectious disease, are we willing to take small sacrifices for ourselves to benefit others who might be vulnerable and at risk? And there, I think we have a very mixed, at best, set of experiences as a nation. And I think countries like the US, similar to countries like Brazil, Russia, India, where there are high degrees of difference between the wealthy and the poor, did quite poorly when it came to looking out for one another, whereas countries that had a more egalitarian societal structure did much, much better. So we got to look at ourselves, not just on the scientific front, not just on the preparedness front, but we really have to look at how the role we all play as individuals, because what we don't do as individuals, as you all know better than anybody, gets thrust directly on the doorstep of the healthcare system and our frontline workers.
Because Andy, just a quick follow-up. I think as healthcare people, we were shocked, because we're generally agnostic to the politics. We figure out what's best for patients and communities, and that's what we do. So I thought everyone was going to line up for vaccines, and as soon as we'd vaccinate the whole country and we'd get on with everything. And part of what we've been worrying about is what's the role of social media in terms of trying to get efforts like COVID accomplished, and what does it look like for the future? How do we counter detail what's out there?
Well, I'm afraid that our challenges increased, not decreased today. Things that were uncontroversial, like getting children the MMR vaccine, are now all of a sudden viewed by more and more people as a sign of defiance. And what's at root here? You talk about, Rod, social media and misinformation, but what is really at root is there is a deep mistrust of institutions in this country that, depending on how you measure it, something in order of 1 in 5 Americans have deep distrust of all of our institutions, government, healthcare systems, pharmaceutical companies, the FDA, the CDC, to be sure. And those are things that preceded the pandemic, but really showed up during the pandemic. And I would like to say that this is just about getting the best information to people, but too often political leaders, social leaders, other leaders will take advantage of a moment of disruption and use it to further create divisions. And so I'm afraid that we are, to a certain extent, a victim of the fact that a lot of people in this country don't feel connected, don't feel trusting. Now, I think you all are part of the path back, because while they don't trust institutions, they trust physicians, they trust nurses, they trust individuals in their community to a high degree. And so having local conversations, connecting to people on their terms, and really promoting dialogue, even if it's going to take 5 or 10 years to earn the trust of people, is really the only path we have at our hands.
Absolutely. Let me, as we're talking about data and information, Terry, we're glad that you're here to talk to us a little bit about that. And as we knew during the pandemic, data was crucial. And we had to put a lot of it together on the fly, so to say. COVID data really, drove the news every day, on social media. It had different potential and challenges. So what I'd like to say is that in real time, how do we coordinate data? How do we use it to our advantage as we go forward? And what are you seeing in that whole arena?
So I guess I should start by I'm on the American Hospital Association stage. How did I end up here? It really was COVID for me, in the sense that I left Microsoft in 2018. I had gone into venture capital, was just fascinated by the intersection of data sciences and life sciences. And then BJ Moore, your chief information officer, and I had worked together at Microsoft, and it gets me involved in this, looking at the data for COVID. And it just opened my eyes. There was, President Trump is tweeting hydroxychloroquine is a solution to COVID, citing clinical studies in his tweets, and the World Health Organization is tweeting without clinical study evidence that does not work. And the World Health Organization ended up being right, but didn't cite any data when they did that. And then it moved on to remdesivir. Then life science industry was approaching the health systems and offering hundreds of thousands of dollars for data sets so they could understand whether the drugs that were being purchased by the health systems were effective, because they didn't know. And the health systems were unable culturally and technologically to provide the data to the life science industry such that they could learn whether their drugs were effective, but they kept being bought. I then was part of a project between Northwell, Providence, and Trinity to try and collaborate and share their work. And so let's try and share how we're defining a COVID infection This is before there was any standard for it. Let's share how we're counting who's being intubated and the effect of intubation. And there was just no legal or technological way for the groups to work together. And so each health system then retreated back into their own silos, did their own data analysis, their own data science, without being able to share and build on each other's work, which made the data inconsistent. And then the capstone for it all was, for me, as I was then getting exposed to the life science side, there was no data at scale to look at the safety and efficacy of these vaccines that you mentioned, and so the whole life science industry starts leaning on Israel globally for their data. And I just read Edward Borla's book, the CEO of Pfizer, and I guess that was a special deal that Pfizer had to put together with the Prime Minister of Israel to actually provide the data that the life science industry needs. So there's just so many things in here where you say the health systems aren't able to ask and answer questions about effectiveness and studies. They're not able to work together effectively. They're not able to work at all with the life science industry, and the life science industry doesn't have the data they need to make clear and effective decisions to take care of patients. And so in terms of where we go from here, I'm actually an incredible optimist right now because there's 22 health systems in this room that have decided to pool their data together to build a data set that's updated every day, that represents the healthcare of this country. And there's some life science research starting to be done on it. And so I see this world where the health systems can work together, the health systems can work together with life sciences for scientific research, not for selling more drugs, not for marketing more drugs, but for doing those things, which, every time I see now our regulators leaning on data from Israel, I'm just struck by Israel does not represent, we just sat through a health equity panel and thinking about the diversity of our country. The diversity of our country is not the diversity of Israel. There's different ethnicities and different genetic makeups and different diets there. And so I'm super optimistic about what the health systems are doing to build Truveta. I mean, it's why I sort of jumped back in and said this is...
Because I think to Andy's point, the two things that most of us are most optimistic about are the advancements in science, which I have really, as a trained immunologist, really excited about how the collaboration of science around the globe is. And then also data, the realization that to advance healthcare, we've got to accumulate data at scale and use it, I would say, have it used by the people, patients, their providers, their health systems that understand what the power of it is for what I like to say for good reason, not for Facebook or whatever else, but to really understand how to advance healthcare. And if we can do that, we can really, really make changes. And that's what I see. And, we just had the panel talking about health equity. One of the biggest challenges that we have is to really understand the data really well so we do the right thing as we go forward.
I mean, you mentioned not using the data for selling ads. I mean, it's sort of funny where you look at the Truveta team, it consists of 160 people now that have been working on, so many of them have been working at Facebook and Microsoft and Google on machine learning to sell ads. And the reason why they're joining Truveta is we're saying, well, you can use all that expertise you've built and now use it to save lives. And it's quite energizing because, in some ways what we're trying to build is a search engine where you can find patients like this one. For this individual patient, it's just, in the same way advertising technology is find the right ad to map to this person. This is, find the right, what cohorts of patients are like this one, what have they been diagnosed with, what side effects have they had, what outcomes have they had. It's a search problem. Right. And we can solve this. I mean, we can normalize this data, bring it together, we can look for safety, efficacy, we can figure out how to treat patients better with data. And the key, though, is defragmenting this data. We need to bring together the American data.
Yep. So Janice, from the front lines for 2 years, and we've talked some about this at the board, and in sharing the key lessons, what did the pandemic teach you about health systems, patients, community during the pandemic? And every CEO had to stay nimble over the pandemic. but what are the insights that you could have and that you could share, and how has it changed or elevated any of your priorities at ChristianaCare?
Thanks, Rod. And I'm actually going to amend something you said earlier. You talked about COVID the last 2 years as our finest hour. I will say our finest hour is yet to come. And I think one of the ways that we make that happen is by honoring the learnings, the suffering that have been so present in the last couple of years, and committing to making sure that we carry those learnings forward. I think there's a great opportunity. You know, I think in many ways, COVID was the great accelerator of strategies that we were already implementing, certainly issues that we knew needed to be addressed. As one of my colleagues said, that the future suddenly landed at the front door, and we were forced to manage it. And so, you know, as I think about the last 2 years, we have really sort of doubled down on those key strategies that lead to value. And if I were to sum up our overall strategy in a word, it's value. And we define value as how do we create a deeply personalized experience so that each person has the opportunity to lead a quality of life to achieve the health outcomes that are important to them. And how do we respect costs so that care can become affordable? You can't achieve value unless you address equity. One of the places that we really doubled down in was the work that we were doing around equity. I became the CEO at ChristianaCare at the end of 2014, and one of the first programs I set up was our Office of Health Equity. I hired a Chief Health Equity Officer. So as in March 2020, we were well into doing this work, had built community relationships, had set up language services, and really I think, you know, the organization was undergoing a cultural change to really understand that it was the work of everyone in the organization to drive equity. And I remember hearing in March some of those early conversations, COVID's going to be the great equalizer. Absolutely not. And our equity work was very much part of our COVID response from the very beginning. It's how can we be with communities, learn from communities, get the trust of communities, because we knew that there was going to be an issue around access to care for COVID, access to information, access to testing, access to vaccines. And we did a tremendous amount of work in that space. I think the other area that we really have spent much more time in is just the whole issue of racism. And again, the very last conversation we had as an executive leadership team before, you know, the command center got set up and everything got pulled apart was about racism and this acknowledgement that we need to understand the issues and address those issues as an organization. In the sort of weeks following George Floyd's murder, we made a commitment to be an anti-racism organization and made that commitment not only to the people inside our organization, but we took out full-page ads in the News Journal and made that commitment to our community, because I want to be held accountable for the work that needs to be done. If we don't address race, if we don't tackle it head on, we won't be able to achieve equity. I think the other place we doubled down is we had good relationships with community-based organizations. We deepened those relationships, and we stood up a platform, we partner with Unite Us, to actually link those community-based organizations to providers and patients. And that's really important. So often a provider is discovering a social driver of health, recommends a connection to, say, the food bank, but we have no knowledge of whether or not that person is actually going to follow through. And so connecting these great community partners who do this work so much better than we can or do was also really important. So now we have what we call Unite Delaware. The other place where we really doubled down was in data. There's so much opportunity for us inside our organizations to understand where disparities exist. I work with a couple of brilliant data scientists. I am not one of them. I'm not an expert in this. But they have applied the Gini index, which is typically used to look at socioeconomic issues in countries across the globe. So they've applied that framework to our data and built in artificial intelligence, so it runs constantly. And it has the ability, number one, to find a disparity, sort of quantify the extent of that disparity. But even more importantly, there are 8 elements that get looked at. And so we can understand that disparity is primarily driven by race, by gender, by age, by payer. And if you have that information, then you can start asking the questions about how do we reduce the disparity. So just a couple of examples. The data told us that we had disparities due to race in our postpartum population when it came to hypertension and readmissions. The team in Women's and Children's created a program and actually relied heavily on technology and secure texting. We looked at 1,600 women. We not only eliminated the disparity due to race, and the data told us that we had done that, we reduced readmissions by about 60%, and we saved over $300,000 in costs. Sometimes the data, you believe that the data is telling you something, and we had data around our ambulatory hypertension outcomes, and the data demonstrated that we have a disparity between African Americans and whites. We made the assumption it's probably because we aren't applying the right clinical care. So spent a year making sure that the clinical care was appropriate, and guess what? The disparity was still there. And so I think, that really sort of understanding that we've got to use the data because it's not enough simply to build programs and processes. We have to start making a difference. We have to demonstrate impact. We have to show that we're closing the gap. We are launching our new strategic plan. We too amended our mission statement to be very clear about our commitment to equity. And I would just say, zero harm is always there. It's probably in everybody's plan when it comes to quality and safety. Why not zero disparities?
Well said. That's I think as we look forward, I think that's one of the positive outcomes as we've come to COVID, because we've put the bright light on it. Andy, let me ask you, as we continue to transform, you heard what Janice and Terry were both saying. What do you think are the policies and practices that need to take place, that took place during the pandemic? Which ones should remain in place? And then what do you think COVID's done to the trajectory of the field, including the financial impact and consumer demand? So what's put on your hat for the future? Where do you see this going, Andy? Where do you see the field going? And what are some of your thoughts and directions on things that we should be pushing for?
Well, as a system, we hate change unless we have to. And I think Janice and Christiana are a bright spot exception, as have been you at Providence, and I've had a chance to see and witness in both of your organizations an urgency that you've been attempting to inflict. But that urgency got forced as we all got to see real-time response to our flaws, because people lived or died. We saw the disparities show up very quickly. This wasn't done over years, it was done over days and weeks. And so it is a great question, Rod, to step back and say, where should we be making our adjustments given how hard it is to change? The first is, I think we all ought to be focused on the role of your frontline teams and caregivers and how they, is there a better way for them to have a sustainable job where it's an attractive job, where they still want to work? And I don't know the answer, and I suspect many of you are exploring this, but I suspect it has a lot to do with working in teams, having the support of one another, integrating many of the care disciplines together that we have left out. The obvious one being integrating mental health and physical health together, being able to rely upon one another, and rethinking that role and how to make it an attractive role is I think probably job one. Second, I'd say is we've learned a bit about what real access is and what the gaps in access are, particularly in different communities. And I would say, we ought to pledge ourselves as a country that everybody in the communities we live in should have a longitudinal relationship with a care team. They shouldn't be lost in the wilderness, interacting on their own, waiting for a crisis in their own lives. And the fun part, the innovative part, is that relationship can look different. That relationship doesn't have to be inside the four walls of the hospital. It often shouldn't be. It should often be in their home. It should often be virtually. It can be with a paramedic visit. It can happen in many, many different ways because we're going to have to do it with less labor. So that means virtual care for sure, as appropriate, but it also means at-home care, community-based care, all kinds of different ways that you all should experiment with getting more creative and getting work out of the hospital. And then finally, the piece I'll speak to, Rod, that you mentioned is economics. I think if there's ever a greater cry for what Janice talks about as value, this is it. We have, some form of, the ability to carry the resources that we need to take care of people and keep them healthy, when insurance companies are essentially going to get paid for not utilizing those resources and not reimbursing those if we live in a fee-for-service system, isn't going to work. It's only going to work if we can continue to be responsible for, if we can begin to get paid for based on the number of people in the community, and then to be able to specialize and redeploy services in those smarter ways. But it's going to be a very tough call to go through an environment with rising labor costs, where health plans are working to reduce utilization and yet still have the resources necessary to keep the community healthy. So we have to change the way that works, and that is a clarion call for new approaches and new models where people who are providing the care can get paid ample resources for keeping people healthy. That's what you and Janice and many other leaders have been pushing for. It's time to push that over the edge, in my view.
Because Andy, this has been, we just had a board meeting at AHA, and this has been topic one, right? Where do we go from here? And we've been pushing this mantra of value-based care, and we've been saying it's time to freshen the deck a little bit and kind of look at what are the things that really, really make a difference. We know exactly what you said with where our labor is going, where it's going. We can't continue to push things in the same direction. So we really need to look at innovative ways that we kind of reset the table, some of which you've talked about. And what I'd say, Terry, just before we get to the final round, what would you say, in terms of how else could we use the data to address quality, inequities, and new therapies? And then what are the limits or not limits on how much data can be accumulated and how it can be put together?
What are the limits?
Are there limits?
I honestly don't think there's limits. I mean, when I spend time with the researchers and the health systems and the life science side, there's a common interest in having these, being able to create cohorts of patients that are representative, but you want to make your cohorts more imprecise to a particular situation, but still be representative of the country. Then you need big data. You need a lot of data, and you need to link it across health systems, because all of our patients are going to multiple health systems. And then you're always going to have gaps. Then you need to bring in the insurance data to bring it together. And then we've talked about health equity a couple times. The socioeconomic data and the EHR is quite narrow. So we need to bring in, really the financial services industry has by far the best socioeconomic data on every American, because they use it to risk score every American for loans or credit card debt every day. And so, that is what we're trying to do, is bring that whole corpus together at scale. So, but it's a huge amount of data. So I don't think there's any limit, but I think it can really, for safety, efficacy, it's not being studied today on either side. You have clinical studies that are being done at a very small rate, publications that are being made. The system's not learning. I mean, if you look at it, there's just the rate of learning in healthcare about what works, what doesn't work, what's the right way to treat a specific cohort of patients. I think that if I was to, that would be the goal. I mean, it's this learning health system idea that has been around, that I've learned has been around for many years. I think it's the right one. And so I don't think there's a limit on learning, but that's where we need to go. Is we need to every patient should be contributing to the learning, just like and that learning can be taken place at every point of care. It could be taken place when you're looking for new therapies, when you're looking for the unmet needs within a given therapy, at the point of patient care, families, individuals making choices. I just think there's no end to bring data to this situation. I mean, I have to have knee surgery next week for my ACL at Providence, and the doctor's like, well, we don't see an ACL in the image, and I'm like, oh, yeah. Gosh, I wish you could compare that to every other image that's out there. And then there's this, well, you could get a cadaver. There's studies that say it works fine. There's studies that say it doesn't work out so well. That's the least painful option. Or you can go hamstring. That's the most popular option. The studies or you can go patella tendon, or you can go quadriceps. And they're like, it's your choice. And you're just like, oh my gosh, I just want to know, for someone like me, what is my best choice? What are the statistical odds? I think the doctor would want to know. I think I want to know. And the fact that I am now personally in this situation after one bad day skiing, it just reminds me there's so much opportunity to use data to improve patient care and what you hear from the life science side, you brought up economics. I mean, I just have to make this pitch. I mean, there's $50 billion businesses selling health data, selling the data that comes out of the health systems. None of that goes back to the health systems today. And so I think there is an opportunity for this group to participate in those economics in 100% ethical ways. I'm not talking about selling it for, and that was just one of the things that struck me, is that the best data on how to improve patient care is within the health systems.
What I've always said, Terry, is that when you put technology people like yourself together with healthcare people, that's when the magic occurs, because technology people and technology on its own will not solve it. But when you put that together with the caregivers that actually know what needs to be done, that's what does it. And it's the decision making in real time that we really need to have the information on what to do first. What I want to do, I offer usually each year a bunch of predictions, in terms of what's there. What I'd like you to the three of you to add to these predictions. And what was on my list for this year, and this is just 5 of them, was number 1 was we got to heal and rebuild a depleted healthcare workforce. Number 2 was scaling up mental health resources to meet the unmet need. The healthcare data revolution continues to build momentum. The cost of caring for patients is rising faster than the reimbursement from insurers. And then making it easier for consumers to shop for healthcare services. So those were a few of mine that I saw as trends going forward. But maybe, Janice, if I could start with you, what other things would you add to the list?
Well, I think you need to call out health equity. Mm-hmm. I think that has to show up explicitly. And then reflecting on what Andy said, I think it would be a tragedy if we took everything that we have done with virtual care and continue to make it about the visit. I would like to eliminate the visit as the foundation of healthcare. Care should be continuous. It should be driven by data. It should be enabled by technology, supported by people, and it needs to be proactive instead of reactive.
Right. I love it. I think this, we'll get to the quote of the day, eliminate the visit, right?
Yeah.
Andy, I hope you're still with us out there. Yes, you're. Yeah. Andy, what are a couple of things you'd add to the list?
I think the home and the family caregiver are going to take increased focus and how we support care that happens there. Today it's a big, giant black box. You know, we know what happens when people visit us in the hospital. You know, if Terry does what he hopes to do, we can track that data. But 90% of people's lives, and particularly people that are being cared for increasingly in the home, and will be, as people are scared to admit their family into nursing homes, or scared to go to memory care units, or scared to go to skilled nursing. And the only people that can really take care of people, at least in part, turn out to be family caregivers. And, you know, that is a big trend. It's a bigger trend than we can see. It's a bigger trend than meets the eye, because it's things that are often not showing up in the healthcare system. How all of you are professionals and leading your community better health can play a role in that is a reinvention opportunity.
Terry?
It's a prediction.
Yeah.
I think it'd be great if the FDA and CDC were using data about Americans to study the safety and efficacy of drugs and procedures on Americans, which instead of Eastern Europe, Israel, and Brazil, which provides most of the data today. And you know what, I'd love to see billions of dollars going back into the healthcare system as a result of making that possible.
Fantastic. Well, I just want to thank the three of you for all these insights. We could probably go on for another hour or two to flesh this out, but I think these are the issues that are going to face all of us as we move forward, and we've got to have this open debate. And so as we're kind of trying to exit ourselves out of COVID, how do we reconfigure who we are? What do we think about equity, mental health, all those things that we were all talking about in 2019. And then all of a sudden we're here. Now I think we've got to put the pedal down, really make a difference in terms of what we have. And how do you redesign a health system that none of us would have designed the way it is today? And I think it's really up to us and the folks in this room to do that. So appreciate spending time with us. I'd like to thank our three panelists, and we hope you enjoy the rest of the meeting. So thank you all very much.